Good evening, everyone. My name is Chris Anderson. I work with Northwell Orthopedics, and we have an exciting night of lectures for you from some of our surgeons. Um, we are piloting a new digital series and excited for you to join us in learning more about what we have going on in New York City and our Westchester markets. Tonight, we have two special guests, Greg Galano and Joe Lee, who are two of our orthopedic leaders in our Western region at Northwell. Dr. Galano trained at Columbia, did his fellowship at HSS in sports surgery, focuses on arthroscopic surgery of the shoulder, knee, and hip, and also has special interest in ACL repair, meniscus injuries, shoulder replacements, and all things sports. And Joe Lee, who is our chief of orthopedic spine surgery at Phelps Hospital in Westchester, also trained at Columbia and completed his fellowship at Rush University in Chicago, and came back to New York and has been working with us at Phelps ever since. Tonight, we're going to be unlocking the core connection between low back and hip pain, and I'll turn it over to Greg to start us off.
Thanks for the introduction, Chris. It's my pleasure to be speaking in front of you guys tonight. Um, I guess I'll just get started with my slides. Okay, so just to reintroduce myself, Greg Galano. I've been at Lenox Hill my whole career. I specialize in sports medicine with kind of a subspecialty in hip preservation. I serve as the director of hip preservation for Lenox Hill and Northwell. And we'll get into a little bit of what that means. But I think it's pretty important for both a spine specialist as well as a hip specialist to talk about what we're talking about tonight, the core, because that's really the connection between these two systems. And one can have an effect on the other, and the core itself can be part of the issue. So what is a hip preservation surgeon? So one of the first questions I always get asked is, do you do hip replacements? The simple answer is no. I do the opposite of hip replacements. We have very great hip and knee replacement specialists, both in the Westchester area as well as the New York City area. And I work very closely with them. So we kind of make a division on, is this a hip that's going to be able to be preserved, or is it a hip that really needs, some advanced reconstruction with some type of replacement? So hip preservation involves maintaining the native or the natural hip joint, and most of the time that involves using advanced and mostly minimally invasive techniques. So my subspecialty is hip arthroscopy, which essentially means putting a camera into the hip to fix the hip. And so what we're trying to fix is structural issues that can cause pain in both the hip, the back, the knee. We'll get into it in a second. And my main goal is to help people avoid and or delay the need for hip replacement. My overall goals in treating patients with these conditions are to restore their function, reduce their pain, and promote long-term hip health and maintain activity in people who are physically active with sports or exercise or even just life in general. So what are some of the most common causes of lower back and hip pain in general, but probably more applicable to both Dr. Lee and I with our subspecialties. So you can have things as simple as muscle strains or sprains, which can either be from specific injury or just overuse, doing the same thing over and over again. You can have something as simple as arthritis, which is more of a wear and tear. Or osteoarthritis can affect weight-bearing joints. You can also have herniated discs in the lumbar spine, which Joe, I'm sure, will talk about in a minute. And this is the typical sciatica with the pain shooting down the leg, sometimes with numbness and tingling. You can also have problems with the sacroiliac joint. The sacroiliac joint is the joint that joins the pelvis to the lower spine. And it's a very close connection between the hip and the lower spine itself. The things that I deal with most commonly, things like labral tears, which are essentially a tear in the suction cup or the gasket that surrounds the hip socket, and a condition that we refer to as hip impingement or femoroacetabular impingement, or FAI. This is what we're showing here on the side. And basically, what we're looking at here is abnormal contact that happens between the front edge of the ball and the front edge of the socket, usually because of the shape of the ball and or the socket. The issue then becomes the labrum is the little triangle that sits on the edge of the socket, and that's what first gets damaged when someone has impingement. If the impingement goes on far enough, you can create the risk for arthritis in the future because the cartilage of the hip socket can be damaged. But there are other hip conditions which are not necessarily inside the ball and socket itself, but they're still considered athletic hip problems, things like bursitis, tight hip flexors, tight hamstring tendons, and then you can actually have core muscle injuries, injuries to the muscles that attach to the pelvis. And so when we're trying to sort it out, is it the hip or is it the back? What I'm trying to show here in this picture on the right side is you can see that there's a variety of nerves that can cause or do cause sensation to the hip. And so you can sometimes end up with what we call atypical hip pain. So I would say probably at least 50% of the patients that I see, their initial complaint was back pain. And it's very, very common to, by process of elimination, eventually realize that it was actually their hip the whole time. So people can present with back pain, knee pain, pelvic or genital pain. These could all be hip pain masked as something else. You can get what's called referred pain, which is pain in one area of the body, which then radiates to another area of the body, depending on where those nerves are headed. You can have increased stress above or below the hip due to limited mobility and or limited strength. And you have to realize that the femur is both the ball and socket of the hip. It's also the thigh bone, which is the top part of the knee joint. The acetabulum, which is the hip socket, is also part of the pelvic bone, which is involved in the sacroiliac joint, which is basically the connection between the pelvis and the spine. And so a lot of patients have both problems, and a lot of patients can have, bad discs in their lumbar spine. They can have a labral tear. They could have arthritis in their hip, and one feeds off the other. So why is hip impingement so important with respect to the back? Well, we know that in certain lab models that if you have impingement in your hip, you transfer that force up and down your pelvis. So it goes up to that sacroiliac joint that joins with the lower spine. It also goes to the joint in the front of the pelvis called the pubic symphysis. In terms of the lumbar spine, what I'm showing here on the bottom is actually they measured the pressure in discs in the lumbar spine and found that it goes way up when somebody has impingement of their hip, because essentially they're pinching their whole pelvis and all that force goes up to their lumbar spine. And it's been known in several studies that hip impingement can lead to less pelvic range of motion, limited flexion of the lumbar spine, and decreased something called pelvic incidence, which is basically the tilt of the pelvis. And we also know that if a hip has an increased angle at the neck of the femur, that increases the force in the little joints in the back of the spine called the facet joints. So why is the core important in terms of both back and hip health? Well, the definition of the core is the abdominal muscles, the oblique muscles, the lower back muscles, the glutes, and the pelvic floor. And these all act to stabilize both the spine and the pelvis. And maintaining a strong core is important for proper alignment. It can absorb force during movement, and it supports daily activities like walking, lifting, and then obviously upper level physical activities like sports, running, twisting, jumping. It does act as a bridge between the upper and lower body, and it prevents excess stress on the hips and the lower back. So it kind of offloads both of those joints. So why would core weakness contribute to pain? Well, weak core leads to imbalances. It can lead to poor posture. It can lead to poor pelvic tilt, and it can cause compensatory movements that then overload either the back and or the hip. And so this can cause pinching in the hip joint, as we just referred to as impingement of the hip. It can also cause excess wear of the cartilage, which is the beginnings of arthritis. It can cause muscle fatigue, and you can have chronic pain as a result of it. And in athletes and active individuals, hip muscle imbalance is directly linked to increased low back pain risk. And what I'm showing here in these four images here, uh, there's basically a four direction balance in the muscles surrounding and crossing the hip. You have the hamstring muscles in the back, you have the hip flexor muscles in the front, you have the abductors and the iliotibial band on the side, and then you have the groin muscles, also called the adductor muscles, on the inner part of the leg. And all these have to be properly balanced for a hip to maintain the force in the proper areas. So what do we do to diagnose these types of hip problems? So obviously, physical exam, putting, your hands on a patient and examining them and asking them, what their history is and what exacerbates their problems, that's probably the most important thing. We assess strength, flexibility, and what causes pain, what doesn't cause pain. And then when we go a level beyond that, we start with things like x-rays. But then for the hip, we've had a pretty rapid evolution over the last 20, 25 years in terms of our diagnosis using things like advanced MRIs. And even what we see on the bottom right hand here is actually a 3D CAT scan, which we often get through our offices to show what is the deformity of the hip and how can we correct it. It actually helps with planning and treatment during surgery. And so we can also determine if there's a core weakness or a structural hip problem, or are there both things present? Because that's very common to see both at the same time. So what are some basic, non-surgical, non-invasive things that you can do to work on your core? These are things that, obviously I would defer even to a physical therapist for more, advanced background and more in-depth advice, but things as simple as, doing a bridge where you lie on your back and extend your hips and engage your glutes. Working on a plank, which either you can do, with your hands, your forearms, you can do it on the side or straight on. And that helps build endurance. And then you can do things like bird dogs or dead bugs, where basically you're doing alternating upper and lower extremity to help with stability. Things that I personally like to teach patients as a hip sports surgeon or sports medicine specialist. Things for stretching the hip flexors. I really like to do, lunging stretches with modified warrior poses, as in yoga, for things like a tight iliotibial band or a tight hip capsule, a figure four stretch, or also called reverse pigeon pose on the upper right-hand corner. That's a very good stretch to do. Clamshells, which are basically just with bent knees, opening up the legs, and side lighting raises. Both of these are very good for the glutes and the abductors to increase the strength of the hip muscles on the outside. So when and why does surgery become necessary? So with hip arthroscopy and hip surgery of this nature, we try to be as conservative as possible. We treat people for months with non-surgical measures, including physical therapy, core work, sometimes injections. But if there are structural issues which persist symptoms like labral tears or FAI, femoral acetabular impingement, then hip arthroscopy is really a good tool to treat something like this. And if it is refractory to, what we call conservative measures, hip arthroscopy can be very helpful in treating these. So what do we do arthroscopically and how do we do it? So hip arthroscopy is minimally invasive. It's little poke holes. It's a small camera in the hip. It's tools like we're using here on the right side to perform things like labral repairs, which is what we're seeing on the right side here. The top image is a labral tear, and the bottom image is a labral repair after I've repaired it with sutures and anchors. You can also reshape the hip bones, which is pretty amazing, done through little poke holes. This is an example of a very large bump, or what we call cam lesion, which caused impingement. And that's the before. And then this is after I shaved it down. And mind you, this is all done through, quarter-inch incisions. So there's no, opening the hip and, dislocating the hip or replacing the hip. This is all done on an outpatient basis, which leads to, faster recovery, less pain, and obviously a lower infection risk and lower risks in general, like bleeding. So the philosophy of hip preservation is we focus on repairing and preserving the native hip rather than replacing it. This on the right side is an example of a patient that I treated, and you can see the hip on the left side had already been replaced. hip on the right side had the same condition, just not progressed to arthritis, and there wasn't a need for a hip replacement. And I was actually able to reshape this hip. And this patient is now 5+ years after surgery and never needed a hip replacement on the right side due to the fact that we were able to preserve the hip. And so it's ideal for younger patients to prevent arthritis and maintain activity levels. And our surgery is integrated with a postoperative core strengthening program, which we use for optimal outcomes and fast recovery as much as is feasible and safe. So what I like to do in terms of my recovery, I'm very progressive, meaning I don't like to keep people bound up in bed or non-weight bearing. I make them actually weight bearing as tolerated. I do use a brace like you see on the lower right-hand corner here, but I get them on a stationary bike immediately the day after surgery. They're in physical therapy right away. My goal is for an athlete or someone who's very active to be full recovery, full sports, usually by about 3 to 4 months after surgery, which online you can read sometimes they say 6 to 12 months, which I think in my personal hands that's not realistic, and a lot of patients don't want to wait that long to recover, and when it's not necessary, there's that further compounds things. So we focus on gradual core exercise to rebuild strength and stability. Our outcomes are significant pain reduction, improved mobility, and return to sports at a high level. So what are the preventative tips for long-term relief? Well, as a hip preservation specialist, I would say you want to maintain core strength with regular exercise, like we discussed earlier. We want to practice good ergonomics at work. So having a high seat, a low seat, an awkward position is not good for you. And during activities, things like, proper squatting during exercise. We want to address pain early with physical therapy, and we want to stay active but avoid overexertion. So we see a lot of overuse injuries, and some of that, as we said, is due to form. Some of that is due to ignoring things. And so I would say consult a physician, and probably even more importantly, a therapist for persistent pain. And the biggest thing I always tell patients is don't push through it. I think, from my perspective, I would say if something is repetitively causing pain, then there's probably some damage being done. And that's kind of the name of the game in terms of hip preservation. We don't want you to go the next 20 years and keep doing this, because that may lead to the day when you need a hip replacement. We don't want that to be an issue in somebody who's of a young age. So I would say, in conclusion, core strength is foundational to unlocking the relief of both lower back and hip pain. For structural issues, hip arthroscopy and a preservation approach offers effective and lasting solutions. And last, I'd say consult a specialist like myself or Dr. Lee for personalized evaluation and care. These are just some examples of athletes that I was able to return. These are all after hip arthroscopy. And this goes from the high school to the college to the professional level. And so I think it is a great technology that we have available to us now, and we're recognizing and treating these problems much sooner than we would have, I would say, again, 20 to 25 years ago. Thank you.
Thank you, Greg. We'll pause briefly, see if anyone has a quick question or two. If not, we'll save questions to the end. And I apologize if I look weird in this. I just lost power at the house and I'm on a hotspot, so still making it work. All right, if no questions, I'll turn it over to Dr. Joseph Lee, who's our Chief of Orthopedic Spine Surgery at Phelps Hospital in Westchester, to take us through some lower back related orthopedic issues.
Thanks, Chris. Hopefully your power comes back on soon. As Chris said, I'm the Chief of Spine at Phelps Hospital. I've been there since 2018. Dr. Galal and I used to be residents together at Columbia many years ago, so it's good to see him again and presenting these topics for Northwell. So why talk about back pain? It's probably the most common complaint that our primary care doctors will see. The good news is that 90% of people will get better, but the problem is, of that 90%, almost 80% will have a recurrence of back pain. It's probably the number one reason why people are out of work, and we spend quite a bit of money per year treating back pain. Now, back pain can be caused by wear and tear, but there's also a genetic component to back pain. This was a study done many, many years ago, probably would not be approved nowadays from a bioethical standpoint. This group put a needle into patients' discs, and they were able to measure the amount of pressure that was seen inside the disc while the patient did certain activities. And you can see here that the maximum amount of pressure seen inside the disc was when someone's leaning forward or getting up from a seated position. Laying down, laying on your side, or standing upright was the least amount of stress. So what are the four causes of back pain? And I like to make things in orthopedics when I see patients in the office. It's very structural. So the four things in the back that can cause pain are muscles, bone, discs, and nerves. And this is just a picture of an MRI, a cross section of you, and you can see the spine here in the middle. You'll see first the muscles. I think muscles are probably 90% of the cause of the back pain that we see in the office. And as Dr. Galano alluded to, this is the core that we talk about. The yellow muscle are the hip flexors. And then you see the pink, blue, and green. And these are some of the back muscles that come together that help with our function. So everyone thinks the core is the six-pack muscle and the oblique muscles, which they are important. But the true core of the spine is actually the hip flexors and the back muscles here. Discs are obviously the second most common cause of pain. There's two parts of a disc. You have the outer frame, which is that tough kind of tire component of the disc, and that contains the inner jelly part. And there's a lot of different types of disc pathology that we see. You can have an annular tear where the outer frame of the disc is torn. You can obviously have a herniated disc. And when these discs continue to break down, you get here what we see on the right-hand side, a degenerative disc, where the disc is completely collapsed. And now the edges of the bone, the vertebrae are rubbing next to each other, and that causes quite a bit of pain. Then obviously you have bones and nerves as the last number 3 and number 4 causes. I'm sure there are a lot of people on the call today who have personally experienced this or have friends who've experienced spinal stenosis, especially if you're above the age of 65. This is an example on this picture right here where this white circle with the gray, that's your nerve space. And then here on the right, you can see how that nerve space gets narrowed due to a combination of disc bulges and bony arthritis. How does this present? If you go to the grocery store, you might see some people leaning on a shopping cart, especially if they're older. I bet you they have some component of spinal stenosis. Their pain gets worse if they're standing upright and walking, and they feel better when they're sitting or leaning forward. You can have deformity of the bone, instability of the bone, where the vertebrae are shifted from a scoliosis standpoint or a side-to-side standpoint. This too can cause quite a bit of pain. Fractures are another common thing that we see in the spine world that can cause quite a bit of back pain. This one on the left, unfortunately, is due to cancer. When the cancer spreads, it likes to go to the spine, and that unfortunately will model the bone, and the bone becomes weak and fractures. But the more common thing that we see, thankfully, is osteoporotic compression fractures. So as people get older, everybody's dealing with osteoporosis. I saw 7 patients today with severe osteoporosis. All of them, thankfully, don't have fractures yet, but the important message to them was for them to really focus on building their bone health. Because as people get older and we live longer, everyone's going to get osteoporosis, unfortunately, and this is what will result. Now, sometimes you can have back pain that's not caused by musculoskeletal issues. You can have kidney stones. In our female patients, you can have OBGYN issues. GI, like the duodenal or stomach ulcers or pancreatitis, is a very, very common cause of back pain. And then you can have autoimmune conditions and Lyme disease. Lyme disease, I call it the great masquerader. It's pretty common up here in the Northeast, especially in Westchester County and even Dutchess and North. And patients will present with, very rarely that bullseye rash they talk about. But if left untreated, they have this kind of multi-joint pain, and one of that main presentation is back pain. As Dr. Galano alluded to, their sacroiliitis is a common cause of back pain. Most commonly, we see it in autoimmune conditions, in our post-pregnant patients, and sometimes we see this after our surgeries. And unfortunately, it presents very similar to our disc pathology or disc arthritis at the bottom few levels. And the treatment includes therapy, injections, and sometimes a small surgery. When we see patients, every patient that comes to my office, we do a history and physical. We get x-rays. We like to get MRIs. And then sometimes we'll do blood tests if we're not convinced that the back pain is musculoskeletal. At Phelps and at Lenox Hill, we now have a new imaging modality that we're using to help identify pain generators. It's called a SPECT-CT here. They merge a bone scan plus a CAT scan. And it allows us to identify potentially more clearly than an MRI where the exact back pain is coming from. So here's an example of a patient of mine who did this fusion with the screws and rods 3 years ago, and he comes in with lots of back pain. And looking at the x-rays, all the instrumentation looks intact. And so this is what the SPECT-CT looks like. The picture allows us to identify different sites of biologic activity that we equate to as bony inflammation. And so you can see all the rest of the metal and the surgery that we did in the past looks great. But below that surgery, you can see this increased uptake at that level. And so instead of having to revise everything, all we had to do was extend the fusion one level lower, and he's significantly better. So there are newer imaging modalities and diagnostic modalities that can help us now to identify different causes of back pain. So how do we treat this? As Dr. Galan alluded to, it's a pretty standard process. We like to do non-operative treatment first. Our national spine societies, we've compiled a lot of the data to show what is beneficial or not. And so the level 1 data supports the use of Advils, Aleve, and Motrins and other NSAIDs, and physical therapy and cognitive behavioral therapy. Now, sometimes people have worsening pain and they want stronger medications, but in fact, the data is mediocre to support of it. And a lot of times we'll use muscle relaxers, steroids, and narcotics to treat back pain, but the data there is not as strong compared to using Advils, Aleve, and physical therapy. So this is one study that really spine surgeons are shameful about. This is a study that actually compared physical therapy, cognitive behavioral therapy, compared to a fusion for patients who had chronic low back pain. They had 64 patients, back pain for about a year. One group had a fusion, one group had physical therapy. And you can see at the year follow-up that the success rate was very similar between the two groups. So from a surgical standpoint, for chronic low back pain without numbness, without pain shooting down the legs, this is one of the major studies that was presented in the past that made us really recommend physical therapy and non-operative treatment for pure chronic low back pain. There are other non-operative management options, including acupuncture, ultrasound, yoga, medical marijuana. In the spine world, medical marijuana has become much more popular. And with its recent legalization in the state, we've seen this more and more. There's two different components, THC and CBD, and they work a little bit differently. And there's been several studies showing support that can help reduce the need for opioids in patients who suffer chronic low back pain. Epidural injections are another common thing that we recommend for treating back pain. And again, this is a very important study out of the New England Journal of Medicine. It's a very popular, a very important journal. And you can see in this study that they compared patients with epidural injections versus lidocaine, and they showed that the injections were very effective. This is a newer procedure that's come out in the last 5 to 10 years. This is also being done in our Northwell system. It's called the Intracept procedure. It's another pain management option that we can utilize to treat low back pain. It's probably in the past, we used to have just epidurals, and if the epidurals didn't work, we would go to surgery. Now we have this procedure called the Intracept that potentially can allow us to treat this chronic low back pain. And if the downtime is very low, it's an outpatient procedure. And if it works, great. The studies showed about 70% reduction of back pain for 5 years. And if it doesn't work, then we could always potentially talk about surgery. So when is surgery required? In my world, most of the patients that we end up offering surgery are people who have severe persistent pain despite all the non-operative treatment options. Very rarely you can have a neurologic deficit, like a foot drop, or you have difficulty with bowel bladder function, that typically requires surgery. And obviously, if you have a fracture or tumor infection, we will recommend surgery as well. And so, to me, if I got a penny for every patient that came in that said, "Oh, they told me never to have spine surgery because it never works," I would be a rich man. But I would say that spine surgery for the right indication is a very effective procedure. This is one of the more famous trials that we have in the spine world, comparing surgery to non-operative treatment for these separate conditions: herniated disc, stenosis, and spondylolisthesis. And every study in those particular pathologies at 8-year follow-up showed support that surgery was more beneficial than non-operative treatment. So this is a type of surgery that we do called a microdiscectomy. This is done minimally invasive through a small tube that's about the size of a quarter, and this is obviously done outpatient. We can do lumbar fusions now for spondylolisthesis, arthritis, and scoliosis, and now we have a lot of different ways of doing this, both open, minimally invasive, and a different variety of approaches. I think everybody knows Tiger Woods, and this is not his MRI per se, but this is the kind of surgery that he had done where the bottom disc was very collapsed, which you can see here, and they placed a cage here anteriorly to help restore his disc space. And after his fusion surgery, he actually won the Masters, which is a famous golf tournament. So a fusion does not mean that you can't get back to living your life. There are a lot of different advances in how we treat back pain surgically. And again, this is all readily available at all of our hospitals in the Northwell system. We have navigation, robotics, motion preservation. We work with our anesthesia colleagues to help minimize how much post-op pain people have after surgery. So, back when Greg and I were residents at Columbia, this is kind of what spine surgery looked like. Big open incision, we strip all the muscles. You can only imagine how much this hurts. And so now, one of the things I really focus on is minimally invasive spine surgery. And so, we can do the same screws and rods and cages, not with a large incision, but 2 incisions that, are about a centimeter each. So things have evolved immensely since we were residents back in the day. Spine surgery has now even evolved more into the MIS world. It's called with endoscopic spine surgery. We call this endoscopic spine, ultra MIS spine surgery. And we use the same equipment that Dr. Galana uses in his hip scopes with a camera and shavers. And we can also perform spine surgery this way. So in our world, things have become a lot more driven to doing things more precise with navigation and doing things more in an MIS manner. And so again, we talked about MIS, robotics. Some people are using virtual reality, and all of this is based off navigation. Stem cells. So I get questions about this quite a bit. There are a lot of bad apples out there. Stem cells in itself can be driven from different sources. My only concern with stem cells is that you have to be a very select patient. I think a disc that's from a 75-year-old who has no cushion left will not benefit from disc therapy. The problem with these stem cells, you require oxygen blood supply to make it work and grow. The disc itself, even in a healthy 21, 22-year-old disc, it's an area where there's very poor oxygen level. There's not very good blood flow to it, and there's a ton of stress in that area. So I am unfortunately not a big proponent of disc therapy, regenerative medicine at this time. There was a interesting podcast back in the day called Bad Batch with this company here, and there were a lot of different complications. Some of the downside, unfortunately, for the FDA is that it's hard to control and navigate all these, and the FDA is working diligently to try to have better oversight for these regenerative medicine clinics. Disc replacements are also a new option that we have in the lower back. Again, the indications are very strict. And in Europe, they've been doing this for 25, 30 years with great success. So it's something that I think will be coming more and more to the United States as well. Everyone talks about AI and ChatGPT. We're utilizing this in our spine world as well in terms of pattern recognition, pathology recognition on MRIs, and using machine learning to identify patients who are at higher risk for complications, et cetera. Another thing that we typically see in our patients who get back surgery is they still have back pain after surgery. So why is that? Sometimes you can have progression of disease at other parts of the spine. Sometimes if you have a fusion, the actual fusion itself didn't take hold and you have something called pseudoarthrosis. You can have an infection. The most common thing that we see is postoperative muscle damage. And you can see here on this MRI where you have the nice hip flexors being very healthy. And then you can see how the back muscles here have atrophied away. So different causes. This is an example of adjacent segment disease where they had a previous fusion done. You can see the breakdown at the level above. Here's the CAT scan. Again, you can see how this disc here is really collapsed and there's air inside that disc. And we ended up doing a lateral fusion on him, which took us about 22 minutes. So again, instead of having to unzip everything and fix all this, we just went from the side in a minimally invasive manner to address this. This is another patient that we saw in Phelps who had a big previous surgery done in a different institution. And unfortunately, you can see that the bottom screws were completely loose and that the cage had literally spit out of where it was supposed to be and compressing the nerves. So in conclusion, back pain is an incredibly common problem that we see. Both Dr. Galano and I see back pain part of our practices. And in my practice, I get a hip x-ray in all my back patients because a lot of times the actual hip is causing some of that low back pain. We always like to start off with conservative treatment. Surgery is the last resort, and we do have significant advances in spine surgery in terms of how we do it, how efficient we are with it, how safe we can be with it. And we're trying to push these to more an outpatient manner. But thank you very much. And my last word of advice, and Greg kind of alluded to this too, it's all about kind of preventing the bad things from happening. So, for most of my patients, we always recommend, even if you don't have major issues on your MRI, to always do some physical therapy, flexibility training, yoga, to avoid the high risk things like CrossFit or heavy lifting, because I think that's the best way to protect our spine and our hips moving forward. So thanks for everyone's attention.
Thank you, Dr. Lee. Thank you, Dr. Galano. We will begin with some questions. So we'll start from the chat. Marianne asked about PT before surgery for faster recovery post-op. Does reshaping the hip cause more arthritis later? So let's start with the first question for physical therapy before surgery related to post-op recovery.
I think that's probably directed mostly at me. Pretty much every patient that goes on to have hip arthroscopy has done pretty extensive physical therapy in lieu of trying not to have surgery. So I would say it is pretty universal that the patients have undergone physical therapy. It's a little different than the situation like an ACL tear where they have to do what we call prehab to recover from the injury, because a lot of the patients that I'm treating for hip arthroscopy have had the symptoms for years. And so they are pretty well versed in a lot of the things that we showed in those pictures with the core exercises and the hip exercises. The most important thing for me is post-operative physical therapy. I think it's essential. I have a very specific protocol that I published last year that we give to the patient to give to the therapist, and it's like 4 pages long. It's a 4-month protocol of, from day 0 to months and months after the surgery. So that's for that question. The question about, what was the second part of the question? I forgot. It was, does reshaping
the hip for arthritis and related to arthritis.
So that picture that I showed with that big bump on the edge of the ball that was causing impingement, if I reshape that, the risk of arthritis goes down significantly. So it's actually the opposite. Reshaping the hip decreases the risk of arthritis unless it's, done in the improper manner, too much bone is taken, or, something funny happens. If it's done in the right way, it's the whole purpose, half the purpose is to prevent the arthritis from happening later.
Thank you, Dr. Galano. The next question, I will go to a spine question for Dr. Lee. For someone with lumbar I guess that's scoliosis, and painful hip osteoarthritis, which one would you recommend fixing first, spine or the hips?
That's a great question. We typically recommend doing the hip first. Hip surgery, in terms of, its ease and whatnot. I think nowadays they're done outpatient. Our hip doctors at Northwell are phenomenal, both anterior approaches and posterior approaches, and people are going home the same day. When you have big scoliosis surgery, it's a major surgery. Our complication profile is 30 to 40%, even in the best of hands, and it's an incredibly long recovery. And so one of the most important factors after scoliosis surgery recovery is to be able to walk. But if you have a bad hip and you can't walk because of a bad hip, it's very, very challenging for you to maximize your post-op recovery after scoliosis surgery. So I typically recommend that they get, whether it's knee surgery or knee replacement or hip replacement first, before they go through scoliosis surgery.
Great. Thank you, Dr. Lee. June asked a question, how do you address gluteal tendinopathy that occurs before hip replacement and persists even after hip replacement?
So I treat a variety of patients with gluteal problems, or otherwise referred to as abductor problems. I think it's a very overlooked area in the hip. Some patients go on to have a hip replacement, and maybe they didn't even need a hip replacement. Maybe it was their abductors to begin with. The other scenario that I see is patients that have had a hip replacement, and I'm actually in the process of writing a series of patients that I've operated on arthroscopically after a hip replacement to repair their abductors, because that's another very overlooked area of abductor tears, whether they're pre-existing or they happen in conjunction with the hip replacement surgery. The nice part now is, particularly at our Northwell facilities, we have excellent MRIs that we couldn't have seen these types of problems 10, 15 years ago, because our resolution is so much better now, and we're able to, when we get an MRI, we have to cancel out the metal in a joint replacement. So we have much more advanced techniques of doing that. And I've operated on, many patients as a result of that, and we were able to, basically clear up their problem, which was probably maybe present all along. So in short order, most of the time with gluteal problems, we try to treat them non-operatively with therapy. I do a fair amount of injections, mostly either steroid injections and/or something called PRP, which is platelet-rich plasma, which actually works pretty well for tendinopathy and/or partial abductor or gluteal tears. If it's a full thickness tear and it's not responding to therapy, and they've done, a lot of conservative treatment, arthroscopic surgery would at some point be on the table if it doesn't respond to anything else.
Thank you, Dr. Galano. Question for Joe. Herniated disc 7 months ago. Limited success with injections. Microdiscectomy was discussed. Can I wait and hope it gets better slowly, or will waiting longer make the surgery less likely to work?
That's a great question. The big decision for you, or whoever asked that question, is to see how much this pain is affecting your quality of life. Surgery is obviously a good option for you at this point. If you have failed all the treatment options, including therapy, medicines, and shots. And if you've waited 7 months to do something, I'm assuming that your pain is not, 10 out of 10, you want to cut your leg off kind of pain. Because most people in that scenario cannot wait 7 months to go through this. Disc herniations, fortunately, do get smaller. We just don't know how fast and how much. They get smaller because in America, we can't get a serial MRI because of insurance companies. But I see time and time again, disc herniations getting smaller on their own if I get an MRI, at a yearly interval. So to that particular question, I would say that you don't have to get surgery if you can live with the pain. Disc herniations can get smaller. All of the non-operative treatments that we recommend are just buying us time until you decide whether or not the pain is livable or not. So the question is really personal to yourself if you can live with the pain. There's no long-term damage. If you end up getting surgery at 6 months or a year, there are some studies showing that if you wait longer than 6 months, that your outcomes are not as good if you do it within 6 months. But in the end, the overall outcome is better than non-op. So I wouldn't rush into surgery unless you feel like your pain is untenable.
Thank you. Next question. Is it possible to have severe back pain coming from the hip or hips, even after total hip replacement on both hips?
Severe back pain coming from the hip after having severe back pain coming from the hip after having a hip replacement.
After having a hip replacement on both hips.
I mean, I guess it's a possibility. I would say it's pretty unlikely if you already had the hip replacements. I would defer to a joint replacement specialist. Sometimes there can be some, intricacies of the surgery in terms of, the positioning of where the hip replacement is positioned. Sometimes that can have an influence on how things function. I would say it's probably pretty unlikely though, after having had both hips replaced, for that to then be still a cause of back pain. I think that's unlikely.
Yeah, I would agree with Dr. Galano. I mean, if the hip implant or the hip replacement device is in appropriate positioning and there's no loosening or issues with that, more likely than not that the back pain is not coming from the hip replacement, but coming from the back, from the spine. And if someone's having bilateral hip replacements, I'm assuming they're in their 60, 70-year range, and I'm assuming that there's going to be some back pain, intrinsic back pathology as well.
Thank you, Dr. Lee and Dr. Galano. Next question. What percentage of patients with severe spinal stenosis in lumbar spine have successful surgery, especially if epidural and medial branch block ablation have really made no difference?
That's another great question. The SPORT trial showed about an 85% success rate, which is one of our trials that I presented before. It was a randomized controlled trial, prospectively done, comparing non-operative treatment in both groups. One group stayed non-op, one group ended up having surgery. And the surgical group at 8-year follow-up was 82% better. Now, the other 20%, what could it be? Obviously, there's always risk of adjacent segment problems and things of that sort, but surgery is a very, very good option for that candidate.
Thank you, Dr. Lee. Another back question. I've had multiple low back issues, history of herniated bulging discs, diagnosis of degenerative disc disease, uneven disc and scoliosis, sacroiliac instability, pain in the hip area, but feels like the tissue is being pulled. How would you diagnose where the primary pain is coming from, and what type of doctor can do this diagnosis? Do you have doctors in Suffolk County for diagnosis and treatment? So, Dr. Lee, I'll have you answer the medical question, and then I'll talk about referral.
Sure. So, with regards to your complaints, obviously seeing a spine specialist or pain management specialist would probably be the best first start. Our diagnostic would obviously start with the physical exam, and we'll see if you have numbness or tingling. We'll see if certain maneuvers will aggravate the SI joint or the hip joint versus the back. And we can do that in the office. We obviously can get x-rays of your back and your hip to see, if there's any overt pathology in any of those regions. An MRI is probably going to be necessary, at least for the back. And then typically, if there's, say, low back issues versus SI issues or hip issues, and we're not crystal clear, or if you have pathology in all different areas, we'll recommend injections. And it'll be both diagnostic and therapeutic, and they'll do it sequentially. So they might do an SI shot first, a hip shot second, and an epidural third, and see where you get most of your relief.
Thank you, Dr. Lee. As for referral to see someone in Suffolk County, I did post in the chat a link and as well as a QR code. If you click the link or scan the QR code with your phone, it'll bring you to a page to fill out some information, and that'll go to our call center team. Just reference that you got the information from the talk tonight and what you're specifically looking for in the box at the bottom of the page, and someone from our team will call you tomorrow and get you in to see one of our spine specialists in Suffolk County. Next question. Severe osteoarthritis in the left hip. Was told might need a hip replacement. Was referred to two surgeons, but have yet to be evaluated. What can I expect from an evaluation?
Yeah, so I can definitely help with that one. Obviously, as we talked about in the talk, physical exam, history, what exacerbates your problems, what can you do, what can't you do, how is this limiting your life? That's the, easiest and simplest thing to start with. But in terms of, diagnosis for hip arthritis, really X-ray is kind of the gold standard in terms of diagnosis. Depending on the hip replacement surgeon that you're seeing, as I think Joe pointed out, and even in his talk, there's different ways of doing hip replacements. And again, that's not my area of expertise, but I would say, you can talk to a surgeon about, is it an anterior approach? Is it a posterior approach? Is it an inpatient surgery, meaning stay overnight in the hospital? Is it outpatient surgery done at a surgery center? And then there are, different techniques in terms of planning the surgery as well. Now there's, at Northwell, we have at least two different types of robotic assisted hip replacement techniques. And that, again, is kind of top of the line in new technology, sometimes involving a CAT scan, sometimes just involving X-rays. Most of that is focused on just making it a very reproducible and very accurate placement of the hip replacement, because that's one of the most important things in terms of longevity. If a hip replacement is put in a good position, it has a much greater chance of lasting your life than if it's in a, not so great position. It may have to be revised in the future.
Thank you, Dr. Galano. Another question, a little different. Question related to blood thinners. Mentioned side effect of back pain. Is lower back pain associated with these or other medications?
Um, I don't think um, taking Xarelto or Eliquis equates to low back pain per se. Now, obviously, if you've had an intervention in the back and you are on blood thinners, you are at risk for developing what we call a hematoma, and that can result in quite a bit of back pain. But I'm not convinced that taking Eliquis or Xarelto uh, in itself will cause back pain.
Thank you, Dr. Lee. Another question, clarifying question from earlier in the talk. Did Dr. Galano say back pain may actually originate from the hip, or was it vice versa?
So the answer is both. So, it could be hip pain or hip problems causing back pain, or back problems causing hip pain. Both from a neurologic standpoint in terms of the way that the nerves are arranged. Radiculopathy, which is pinching of a nerve in the spine, causing pain down the line of that nerve, or alternatively, what we call referred pain, which is pain that travels to different areas based on how the sensation of that joint is aligned with the hip. There's a pretty wide web of the nerves that cause sensation to it, and then just mechanically. So a stiff hip puts increased pressure and stress on the lower back, and vice versa. A fused spine or degenerative spine is going to transfer, stiffness and potentially pain down the line to the hip as well.
Thank you, Dr. Galano. Um, Next question, similar to, had recent, well, this is a little different. Possibility of back pain coming from the hips. Total hip replacement done on both hips, but one was replaced 19 years ago and the other one was replaced 23 years ago. The patient is 78 years old. Might that time element make a difference?
I mean, certainly, hips that were done a long time ago, there could be, issues with those wearing out or loosening, or, there's a variety of things because the technology from, 20 plus years ago was obviously a lot different than the technology today. Again, I would see someone who's specialized in joint replacement and what we call revision joint replacement or complex joint replacement to assess something like that. There are certain tests that can be done to assess whether something is loose, whether something is out of place. And again, I would defer to a high level joint replacement specialist for something like that.
Thank you, Dr. Galano. Pain running down your back into your leg. You've had shots in that area, but you still have pain. What can you do about it? Caveat, recently just had a knee replacement. Would this help with the back pain?
Yeah, so the knee replacement itself wouldn't address the back issues or the nerve pain shooting down the leg. I think one of the big differences between hip pathology and back pathology and pain caused by that is the presence of numbness and tingling. So if there's numbness or tingling or burning sensation, in my opinion, the cause is going to be the back. So with regards to the back and pain shooting down the leg, from the butt down, is going to be the nerve. And obviously, with workup being done and failing an injection, if the nerve compression is severe enough, that individual will be a candidate for surgery.
Thank you, Dr. Lee. We'll do our last question of the night. 72-year-old female was told many years ago that I need two hip replacements. At the time, I was morbidly obese and was told that the weight to target was 250 pounds or less. Years later, I am now in constant pain in my lower back, which was my original complaint, my hip and pelvic area, and my knees. It is affecting my day-to-day lifestyle, preventing me from doing uh, chores. I've recently lost 37 pounds and continuing to lose weight. Is the rule of thumb 250 pounds or less? I would like to consult with a doctor, but have been very discouraged in the past. I have tried PT, pain management, and acupuncture.
Yeah, so with regards to weight, a lot of studies show that a BMI above 40 increases our complication profile. And so that is one of the main reasons why people have maybe not necessarily weight limitations or weight cutoffs, but at least BMI cutoffs. And but that being said, people who have BMIs over 40 obviously have significant back issues or joint issues. And unfortunately, if they do have a neurologic deficit or a red flag problem, or they fail all treatment options, we would talk to them about potential surgery. Now, the surgery might be different in terms of how much we do, if we do it minimally invasive versus open, endoscopic. And obviously, after discussion, risk and benefits, and if both sides agree to proceed, you are a candidate for something more definitive. But I think the weight cutoff sometimes it's driven by the institution. So I know at Northwell, at the hospitals that I work at, a BMI over 40, unless it's urgent or emergent, we try to hold off. But again, obviously, if there's some emergency that forces our hands, we end up having to do what we have to do. So I'll be happy to see this individual and kind of discuss.
Thank you, Dr. Lee. Thank you, Dr. Galano. Thank you all for joining tonight. Like I said, we posted in the chat the QR code and link. If you'd like to see either Dr. Lee, Dr. Galano, or any of our orthopedists, you can submit a form and our call center will reach out to you and make an appointment. There'll also be a QR code at the end of the video that we show. Please look out for the future. We'll be doing more of these events throughout the fall and early winter to really continue to promote and bring awareness of orthopedic disease to our community. Thank you again. Have a great evening.